Okay, so hello, I'm not Iris, I'm Eric, and I'm actually the CTO of Brainomics, and we're a company that's also based in Oxford, like some of the other speakers already today, and we've developed something called the eStroke Suite. So to give you a quick bit of background on stroke, this is the challenge that we're trying to solve. There's over 100,000 strokes each year in the UK, and over 1 million stroke survivors. It's a huge health problem. It's one of the primary causes of disability and also death in the Western world, and indeed worldwide. And actually, it's the 4th leading cause of death in the UK. One of the key things to know about stroke is that there's 2 different types. There's ischemic stroke, where there's a blood clot, and then your brain starts to die because of a lack of oxygen. There's a hemorrhagic stroke, which is where you get a bleed in the brain, and then the brain gets damaged because of the blood flowing into it. And we're looking at ischemic stroke, which is around 90% of strokes. So by far and away the most common type. So in the NHS, we actually started the company with a collaboration with Southend Hospital. So back in 2010, the company was formed. And in 2012, we got our first Innovate UK funding. And this allowed us to go full-time on the project. That's actually when I joined the company. And we started working under an SBRI grant to commercialize an academic prototype. And I think academic prototype is quite a polite way of putting what we had at the time. But certainly we've now got a product that's being sold in the UK, Europe, and across other countries, so like Brazil and even in the US. So in the NHS, there's huge potential for savings. It's very important in stroke to treat patients very fast. Time is brain. And indeed, the treatments you need to be able to implement very quickly as well. Thrombolysis, which was the only treatment available up until the last 5 or 10 years, you need to administer within 4.5 hours of an onset of a stroke. So the ambulance transfer needs to be fast, the diagnosis needs to be fast in the hospital, and then the treatment needs to be fast as well. Since around 2015, there's another established treatment called thrombectomy, where you can mechanically remove a clot. And this is now being rolled out across the NHS, and it's something that our software can help select patients for. I'll skip through this quickly, just to give you an idea of how acute stroke care is organised. So the first thing is, when a patient has a suspected stroke, somebody hopefully calls an ambulance, and they'll be picked up by the paramedics. At that point, they don't know whether it's a hemorrhagic stroke or an ischemic stroke. So they'll take them to the hospital as fast as possible, where they should receive a CT scan. And once they've had the CT scan, if it's an ischemic stroke, the patient might be eligible for thrombolysis, which is the drug treatment. That tries to break down the clot and restore the flow. Otherwise, if it's a large vessel occlusion, they might be eligible for a thrombectomy. This is where they'll do a groin puncture, feed up a catheter all the way through the vasculature up to the brain, and then feed in a device called a stent retriever, where you can physically pull out the clot, again, using imaging to guide this process. And this thrombectomy treatment applies to around 10% of stroke patients, but it's the most severe 10%, so those patients who are most likely to be disabled. And recent studies have shown that this can even be effective out to 24 hours. So even if you've had a late time of arrival at the hospital or a slow diagnosis, you can still be eligible for thrombectomy. Now, one of the problems with identifying and diagnosing these strokes is actually variability amongst physicians of interpreting the CT scan. So one thing we've done whenever we go on a road trip and go to hospitals and speak to physicians about the product is we ask them, how easy do you think it is to interpret CT scans? Some people will say, yep, I find it quite difficult. Some people will say, no problem at all, I can do this is easy, I'm right every time, I'm an expert. And so what we do is we give them all a bunch of iPads with the same stroke cases on them, same CT scans, and ask everybody, okay, please score these cases. So they're all sitting down in the room with their colleagues, they look at the cases, they score all of the scans, and these are the results that we get. So on the first row here, you can see we've got one case. The green bar here indicates what the true score is. So this is a score that you can get by looking at a CT scan and counting different regions in the brain. And here we can see that an MRI scan for the same patient actually showed that this is the true score. This distribution shows what the physicians in the hospitals actually score for the same scan. Some people score very low, as in the patient has a very, very big infarct, a very, very severe stroke. Some people say there's no stroke at all in the patient. And we did this over 300 physicians from 10 different countries. And you'll see for each case, you get the same kind of skewed normal distribution kind of thing. And in this case, actually, the ground truth is quite a small stroke. And most physicians, or the modal group at least, agree with that. But again, you see this huge distribution of people who see false positives or false negatives in the CT scan. So this is a real problem. Some physicians aren't selecting the patients for the treatment. Some physicians are selecting the patient for treatments that they shouldn't really be receiving. And so what we've done is we've developed a tool which reads the image with AI. Originally, they're kind of more traditional machine learning methods. And more recently, we've got deep learning as well, the kind of UNets and CNNs that you hear about. And we've developed a system worldwide to address this problem. And I'll show you, hopefully, a quick demo of that in a minute. So, as I say, 10 years ago, the company didn't exist. Around 6 years ago, we got our first Innovate UK funding. And today, these are the countries that we're addressing with the software. So we have workforce in all of the countries in green, so across many European countries, in Brazil as well. We're addressing these countries in blue, subject to regulatory approval in the next few weeks. And then we're looking at the additional countries in yellow in the future. So at the moment, we've got hundreds of hospitals across 25 countries using the system. And we've processed over 100,000 CT and CTA scans of acute ischemic stroke patients. So it's having a huge impact already, just a short time after we started. So I guess this is a quick explanation of what the product is. And then if we're really lucky, I'll be able to do a quick live demo, which is always a terrible idea, but I'll give it a go anyway. So eAspects, this was our first product, looking at plain CT scans. And here, we assess the ischemic core by generating a heat map based on a machine learning algorithm. So it looks at the image voxels in the CT scan in a full 3D volume, tries to identify these very subtle signs of ischemia, and then highlights them to the physician. They can then use that as a decision support tool to standardize their results, get better sensitivity and specificity without needing an expert colleague on hand all the time to help them with that. eCTA, this is something that we added a few years ago. I think we started the project again with an Innovate UK grant in 2015, and we released this product last year. So this is looking at CT angiography scans, and it's identifying the extent of collaterals, which is a certain feature of blood flow in the brain, which is if you've got an ischemic stroke, how much secondary blood supply can keep that tissue alive for. And also, where's the occlusion? If you're going to do a thrombectomy, you need to see where is the blockage, which vessel has the clot in it. And if it's a big enough vessel, close enough to the heart, you can feed it that catheter and pull out the clot. And we're going to go live with the clot detection feature, which is based on a deep neural network, in the next 2 or 3 weeks. And finally, we've actually got a partnership with a French company called Olea Medical, who do CT perfusion and MRI scan analysis. And we use that as the third component in the stroke suite, which is the CT perfusion scan. So this is the traditional stroke pathway. You'll see the head CT scan's done first. Then you've got a CTA scan. Based on that, you can decide whether you need to do thrombolysis and maybe transfer the patient for thrombectomy. For some patients in a late time window, new guidelines from clinical trials show that this CT perfusion or MRI scan can help select those patients. So I'll just try plugging this in and let's see what happens. Here we have a quick list of all of the patients that I've pre-processed for demo purposes. And I'll look at one of these cases. So this is a web-based user interface that typically hospital users, such as physicians, can log into. We also integrate with the PACS and so on via DICOM. It's a fully automatic workflow. But this is one of the output formats that we use. OK, so here we get a quick report which summarizes what the software's done. So you can see a plain CT scan's been done, a CTA scan's been done, and a CT perfusion scan's been done. So that's the overview. But let's go into this in a bit more detail. So if we look at a CT scan, typically without the software, this is what a physician would see. This is an image of the brain. I can go up and down through these slices, and I can look for the kind of features that are common in ischemic stroke. If you're not a radiologist, then you probably won't know what we're looking at here, but this is a fairly normal looking brain. You're looking left to right for signs that are different. And in fact, if you're an experienced radiologist, you might be able to see that somewhere around here, there are signs that look a bit different to the other side. It's very subtle imaging signs. We can change the window to make it higher contrast. And now you might be able to see there's this bright kind of ribbon around here, just inside the black bit. And on the other side, it's a bit darker. You see this? These little bright areas here and the slightly darker bit there? Those are the really, really subtle signs of ischemic stroke that you're looking for. In fact, if Professor Ford was here, he could probably do this better than I can. I'm not a radiologist, but he's a stroke physician, so he would know what he was talking about. If we look through this whole scan, we've got to try and evaluate how big is the stroke. So the aspect score is a standardized scoring system where you look in all of these regions and try to identify how many of them are damaged. And what the software does is on the right. So first of all, it automatically segments the brain into these different regions, as according to the scoring system. And then it starts to highlight those regions with signs of ischemia. So if I turn off the regions, you'll see there's a heat map. And this is going back to the explainability that people were talking about earlier. It's really important for the physicians to understand how the software's come up with a score. If we just said the aspect score is 8, then the physicians would say, OK, maybe it is, but can I trust this result? Maybe they don't think it's 8, and they don't know how to decide whether the software's right or they're right. So the first thing we do is we generate a heat map looking at all of the voxels and saying which ones are affected. So you can see these voxels around here that I was pointing out earlier, they've been shaded in red. Then what we do is we automatically overlay the regions, and the physician can then decide if they agree with the score or disagree with it. If they disagree, they can edit. But 99% of the time, they'll look at the result and use that as part of their decision support. Then if they do a CTA scan, this isn't what they'd normally see. They'd normally see something that just looks like this. And now it's even more difficult. So this is exactly the same kind of idea. We've done a CT scan of the brain, but this time it's with contrast. So the contrast agent highlights these blood vessels within the brain. And if we go down to the bottom, we can see the circle of Willis level. And around here, this is where the internal carotid artery turns into the MCA, and you've got blood flow coming up here as evidenced by the bright white pixels there. And you can look on this image, and you might be able to see visually, a lot easier than the last one, that on the left side of the brain, which is the right side of the image here, because we're in radiology land, you can see that there's a dark patch. There's not so many vessels visible there. But the question is, where is the blood clot? So it's not up there. All of that's missing its blood vessels. It's somewhere down here. One of the first things we do, even before doing any AI algorithm, is generate this MIP image. So this is a maximum intensity projection. We take all of the slices and generate a much, much easier to understand visual image which combines all that data. So this is before we do artificial intelligence. Immediately you can see there's a blockage in this vessel here. You don't need to be an expert. You can see the vessel tree on this side is all fine, and it stops right here. The second thing we do is automatically apply a deep learning classifier to try and highlight where that contrast stop is, and that's what the red circle is showing. So now we can automatically flag to even physicians in a small remote hospital, you've just done a CTA scan and it looks like there's a large vessel occlusion. This would be accessible by a thrombectomy device. So this patient is probably suitable for transfer to a centre like the John Radcliffe Hospital in Oxford, and then they could do a thrombectomy. So this can help physicians decide, even out of hours in the middle of the night, which patients should go where, who should get which treatment. And overall, if we look at the results here, the software can also highlight those vessels to show how it's making the decision so people understand how the software has come about this result. It can quantify things like the percentage of the missing vessels. You can see these orange highlighted areas over here, and they're quantified with this 45% relative to the contralateral side. So you've got all of these features. You've got measurement, you've got decision support, and you've got a nice visual output, which people can't do by themselves. And that's basically what we're trying to do, quickly bring all of the imaging to the physicians, even if they're not experts in stroke, so that they can route those patients to the right treatment and save every minute that they can to get the best treatment outcomes. So I think that's probably enough for this, but thank you very much. Yeah.